Good morning, class. Today let us discuss about the acute interstitial disease. Okay. In today's presentation, we'll discuss about the definition, then the type of acute interstitial disease, then etiologies of acute interstitial disease, then clinical features of acute interstitial disease, and we will discuss the one classical interstitial disease, that is allergic interstitial nephritis. Okay. Now let us go to the definition of acute interstitial disease. For that I will make a diagram of the glomerulus, and this is the tubules, this is the loop of Venn, this is DCT, and this is the collecting duct. Okay, this is the glomerulus. We have already discussed about the glomerulus is the tuft of capillaries. So in a patient who have glomerular involvement or vessel involvement, in one stage of their disease progression, there can be the tubules and the interstitium involvement, but that is not tubulointerstitial disease. Tubulointerstitial disease is that condition where there is the involvement of these area, that is tubules, these area tubules, and this area, this is interstitium, this area, this is interstitium, this area, this is, oh no, this is permanent marker, this is area, this is interstitium. Okay, this area, this is interstitium. So if there is a predominant involvement of the tubules and the interstitium and relative sparing of the glomerulus and the vessel, then that is called tubulointerstitial disease. That is what we are going to discuss today. Then what are its type? Depending upon the cause and the presentation wise, it is of two type. Okay, tubulointerstitial is of two type: acute tubulointerstitial disease and the chronic tubulointerstitial disease. Okay, the acute and the chronic tubulointerstitial disease. The cause for the acute are different from those of the chronic cause. Even the presentation are different, even the treatment are different. So there are two types of acute tubulointerstitial disease and the chronic tubulointerstitial disease. So we will discuss the clinical feature of these two types later on. Then what are the etiology? So acute and the chronic. The etiology of acute is, I have make a simple formula: TINA. Formula TINA. So T means therapeutic agent. There are therapeutic agent. Okay. So therapeutic agent, we often get the acute tubulointerstitial disease because of the therapeutic agents. Antibiotics like amoxicillin, fluoroquinolones, these can cause the acute interstitial disease. Other therapeutic agents which are notorious to cause the tubulointerstitial disease are the NSAIDs. NSAIDs can cause tubulointerstitial disease. Antitubercular drug like rifampicin can cause the tubulointerstitial disease. So these are the common therapeutic agents which can cause the acute tubulointerstitial disease. So if someone has the renal dysfunction after using the antibiotics or NSAIDs for few days, and then it may be the acute tubulointerstitial disease. So you should always remember the therapeutic agent as one of the cause. You have to write here NSAID, fluoroquinolones, and you can even write the ATT. IN means infectious cause. There are some infectious cause which can cause tubulointerstitial disease, like in bacteria like Streptococcus, Staphylococcus, Legionella can cause the acute tubulointerstitial disease. In virus like Epstein-Barr virus, hantavirus, this can cause the acute tubulointerstitial disease. Okay. Even malaria can cause tubulointerstitial disease. So, these are the infectious cause. Then A means autoimmune. There are different autoimmune diseases, as you know, like SLE. SLE can cause the, SLE is one of the important cause that can cause the tubulointerstitial disease. Similarly, A means another, A means acute obstructive process, acute obstructive process, acute obstructive uropathy, acute obstructive uropathy, okay, uropathy, like in case of the hyperuricemia, that uric acid can block the tubules, and then that can cause the acute interstitial disease, that is acute nephropathy. That condition is called acute nephropathy. Okay. So, in the acute cause, you already remember T. Therapeutic, T means therapeutic agent, I an infectious cause, A means autoimmune cause, and another A means acute obstructive uropathy. These are the cause for the acute tubulointerstitial disease. Whereas the cause for the chronic are like, one important cause is reflux nephropathy, that usually occur in child. Reflux nephropathy. If someone has the vesicoureteric reflux, then that can cause the chronic tubulointerstitial disease. Another important cause for a sickle cell, in case of sickle cell, they can have sickle cell disease, they can have the chronic tubulointerstitial nephritis. Like another important cause is drugs like lithium can cause the chronic tubulointerstitial disease and can present with the diabetes insipidus. You know, we use the lithium in the bipolar affective disorder, or sometimes even in mania. It can cause the chronic tubulointerstitial disease. So, tubulointerstitial disease has like different cause for the acute and the chronic one. Okay. Then after knowing the causes of the acute and chronic, then how the acute present and how the chronic tubulointerstitial disease present. The clinical feature of the acute is that mostly in the problem with acute is there is the tubules because of the inflammation in the tubules, that is PCT or lupopenia or DCT. There is the blockage of the tubules. So what happened? If the tubules are blocked by the inflammatory cells, then it can cause the oliguria and even anuria. Patient can present with oliguria or even anuria in case of acute tubulointerstitial disease, because tubules are blocked because of inflammatory cells. Another is, when the tubules are blocked, then there can be the distension of the proximal part. Even it can exert more pressure in the renal parenchyma and can cause the flank pain. So, flank pain can occur in acute tubulointerstitial disease. There can be oliguria, there can be anuria. Okay, there can be oliguria and there can be the anuria. So, in the urine, sometimes if there is a urine, then urine you can see the different inflammatory cells, like you can see WBC, you can see sometimes RBC, you can see different cast in the urine. That is the presentation for the acute tubulointerstitial disease. And when there is there is a blockade at the level of tubules, there can be acutely rise in the level of the serum urea and creatinine. There can be acutely rise in the serum urea and creatinine, and patient can die just in front of us. So, acute tubulointerstitial disease has acute presentation. The presentation regarding the symptoms, they can have flank pain because of tubule block, they can have oliguria or anuria, they can have the different inflammatory cells in the urine, and they can have rapidly rising urea and creatinine in a acute interstitial disease. Okay. However, so in contrast to the acute interstitial disease, chronic has the indolent slow process course. Okay. So, usually what is the problem in the chronic is that, chronic tubulointerstitial disease is that there is no blockade at the level of the at the level of the tubules. So urine can form. What is the problem? There is a problem in the process of reabsorption. Okay, reabsorptions and reabsorption. So that's why in a patient with chronic, but rather you may, and there is also problem in water reabsorption. There might be problem in water reabsorption at the collecting duct. So there can be a polyuria. One, in acute there is the oliguria. In chronic there can be mostly there can be the polyuria, because there is a defect in water reabsorption. Similarly, there can be the defect in observing the protein. So there can be the proteinuria. So chronic tubular interstitial disease can be present with polyuria. It can present with proteinuria and different electrolyte imbalance, like they can have the metabolic acidosis or hypokalemia, or sometimes hyperkalemia, electrolyte problem basically. Okay, so chronic tubular interstitial nephritis, in contrast to acute tubular interstitial nephritis, they will have polyuria, proteinuria and different electrolyte problem depending upon the which part of the tubule is involved. They can have hypokalemia, some have the hyperkalemia, some have the metabolic acidosis, some may have the metabolic alkalosis, like that. Some have the like that. Okay, like that. These are the conditions that you will see in a patient with chronic tubulointerstitial disease. So till now we have discussed the definition of the tubulointerstitial disease. The tubulointerstitial disease is a conditions where there is a predominantly involved of the tubules and the interstitium. Okay, it is of two types, acute and the chronic. They differ in cause, etiology and the presentation. The common cause of acute interstitial disease are therapeutic agents like NSAIDs, infectious agents like different bacteria, then autoimmune cause like SLE, then the acute obstructive uropathy. In case of chronic, the one important cause is vesico-ureteric reflux and sickle cell disease. Presentation wise, acute is acute. There can be the blockage of the tubules and can be present with oliguria and anuria, whereas chronic is the indolent process, and they usually present with polyuria and different electrolyte problem. Okay, the different electrolyte problem. So let us discuss about the one classical tubulointerstitial disease, allergic interstitial nephritis. Allergic interstitial nephritis. So allergic interstitial nephritis is one of the important cause of acute tubulointerstitial disease. Okay, the cause of the allergic interstitial nephritis, the important cause is therapeutic agents like NSAID, antibiotic like fluoroquinolones, rifampicin. I have seen so many cases with allergic interstitial nephritis because of NSAIDs and antibiotics and the rifampicin. Okay, so these are the important cause of the allergic interstitial nephritis. So how the patient present? Doctor, I have given the NSAID for knee pain, but after a few days that patient may present with the renal dysfunction. Though the cause for that renal dysfunction may be the vascular cause, but one important disease for that condition is you might be having the allergic interstitial nephritis. Okay, allergic interstitial nephritis. This is how the patient present to us. Then what are the presentation? So clinical feature of the allergic interstitial nephritis is, other than the renal dysfunction, I have already told you what are the renal dysfunction that can occur in the acute interstitial disease. Like they can have sometimes oliguria, they can have sometimes anuria, they can have flank pain. Okay, they can have flank pain. These are renal dysfunction. But other important classical picture is rash. Some of the patient can have the rash because it's an allergic conditions, and allergy. So these are the two common clinical picture. One is they can present with renal dysfunction and another one is rash, another one is lash. So in lab analysis, when you do the renal function test, there can be the derangement in renal function test, like there can be elevation of urea, there can be elevation in the creatinine, but more specific, but that is not more sensitive to the R. One important finding you will get is the peripheral eosinophilia. Okay, peripheral eosinophilia. Sometimes in case of peripheral eosinophilia, and that fulfills the triad for the allergic interstitial nephritis. If someone has renal dysfunction, rash and peripheral eosinophilia, then that is the triad for the allergic interstitial nephritis, and this will be one of your MCQ question. So in the urine you can also get eosinophil in the urine. So sometimes you have to see the eosinophil in the urine, but this is neither sensitive nor specific, but you have to know. Basically, to etiological wise, different therapeutic agent can cause the allergic interstitial nephritis. The classical presentation are feature of renal dysfunction like oliguria, anuria, flank pain, sometimes like different cast in the urine or inflammatory cells in the urine. Other than they can have the rash. Okay, So how you treat? If someone has the renal dysfunction, after using the NSAID or rifampicin or different antibiotics, so what you are going? If there is a suspected AIN, allergic interstitial nephritis, then what you do? First of all, if there is a suspected AIN, then what you need to do? First of all, so what may be the cause for this? Then you have to withdraw the agent. Mean, if you are using the antibiotics, then you have to stop the antibiotics. If you are using the rifampicin, then you have to stop the antibiotics. And you just withdraw the agent, and if you do the supportive care, it's only supportive care. Okay, supportive care. With supportive care, if the patient improves, if the patient improves, then it's okay. Then you observe the patient, do nothing. With only supportive care, you observe the patient and do nothing. But with the supportive care, if there is no improvement, even after observing for 7 days, or rather there is a deterioration, patient is not improving for even after observing for them 7 days, or rather there is a deterioration, then you can do what you can do. If there is a feature of the classic AIN like rash and eosinophilia, then you have to give them steroids. For short period of the time. If there is no feature of classic AIN, then you have to do the renal biopsy. If there is no feature. If in renal biopsy it shows the classic AIN, then again you have to give the steroid. If there is the interstitial fibrosis, already there is a fibrosis process, then you have to give the supportive treatment again, because if there is a fibrosis, then you can do nothing. This is how we approach the patient with allergic interstitial nephritis. Let us revise it again. Oh, doctor, I have the elevation in the urea and creatinine, I have oliguria, and you see the report and you take the history. The patient give the history oh doctor, I have taken the NSAID like that. Then urea is near about 150, creatinine is 6. And there are no other feature, then you might be confused. So in that case, just you wait and observe. First of all, you just hold that culprit antibiotics or NSAID. Okay, then you wait and observe. You just admit the patient and just see what is happening. You give the supportive care. In meantime, if patient require the dialysis, you give the dialysis. You do whatever you can do. Okay, you just give the supportive care. If with the supportive care, then you just repeat the urea, creatinine and other thing. If the patient starts improving, then do nothing, just do the observation. If the patient do not improve, rather there is an increase in urea and creatinine. Now urea become 200, creatinine become 9. There is deterioration of the urea and creatinine. Then what you need to do, you just observe the other feature of classical AIN, like if there is a rash, eosinophilia, okay, then you give the steroid, okay. Otherwise, if you are confused what might be the cause, then you do the renal biopsy, okay, you do the renal biopsy, you immediately find out that renal biopsy report. Then if there is a feature of AIN, then you give the steroid again. Okay. If there is a feature of interstitial fibrosing, already the kidney is fibrosed, then you cannot do nothing. Steroid is not going to act upon that condition. Then you have to just observe the patient. This is how we have to approach a patient with allergic interstitial nephritis. Okay. Now let us revise it again before concluding the session. So tubulointerstial disease is a condition where they predominantly involve of tubules and interstitium and relative sparing of glomerulus and vessel. Excellent. It is of two types, acute and chronic type. The common cause of acute are therapeutic agent, infectious, autoimmune and acute obstructive uropathy. The common cause of chronic are reflux nephropathy. Common presentation of acute are oliguria, anuria, flank pain and rapidly rising urea and creatinine. The chronic are, it is relatively indolent, they usually present with polyuria and features of tubular dysfunctions, that they can have different electrolyte problem, okay, and we have also discussed about the allergic interstitial nephritis, okay. So with this I would like to conclude this session. If you have any comment, then you can write in the comment section. Thank you so much for your kind attention.